Party pharmacokinetics and pharmacodynamics. 1.1 Pharmacokinetics and pharmacodynamics Introduction. Learning objectives. Discuss the processes of pharmacokinetics. Use multiple professional resources, including technology, to identify pertinent information related to drugs. Describe the processes of pharmacodynamics. Consider pharmacodynamic differences across the lifespan. Differentiate among prescription drugs, over-the-counter drugs, herbals, and dietary supplements. Safe medication administration is a vital component of the nursing role. Every day, nurses make critical decisions regarding the safety, appropriateness, and effectiveness of the medications administered to their clients. Examples of decisions that a nurse might make during client care are as follows. Is my client's heart rate within the correct range to receive this beta blocker medication? Does my client have adequate renal function prior to administering this dose of antibiotic? Is this pain medication effective in controlling my client's discomfort? To make safe decisions regarding medication administration, the nurse must have a strong understanding of pharmacology, the science dealing with actions of drugs on the body. Symptom management and a client's overall well-being are strongly connected to the appropriate administration of medications prescribed in a client's treatment plan. Before a student nurse reviews a medication order, checks a medication administration record, or removes a medication from a dispensing machine, it is essential to have a foundational understanding of how medications interact with the human body. This chapter will review basic concepts related to pharmacokinetics and pharmacodynamics. 1.2 Pharmacokinetics. Pharmacokinetics, examining the interaction of body and drug. Overview. Pharmacokinetics is the term that describes the 4 stages of absorption, distribution, metabolism, and excretion of drugs. Drugs are medications or other substances that have a physiological effect when introduced to the body. There are 4 basic stages a medication goes through within the human body: absorption, distribution, metabolism, and excretion. This entire process is sometimes abbreviated ADME. Absorption is the first stage of pharmacokinetics and occurs after medications enter the body and travel from the site of administration into the body's circulation. Distribution is the second stage of pharmacokinetics. It is the process by which medication is spread throughout the body. Metabolism is the third stage of pharmacokinetics and involves the breakdown of a drug molecule. Excretion is the final stage of pharmacokinetics and refers to the process in which the body eliminates waste. Each of these stages is described separately in the following sections of this chapter. Research scientists who specialize in pharmacokinetics must also pay attention to another dimension of drug action within the body: time. Scientists do not have the ability to visualize where a drug is going or how long it is active. To compensate, they use mathematical models and precise measurements of blood and urine to determine where a drug goes and how much of the drug remains after the body processes it. Other indicators, such as blood levels of liver enzymes, can help predict how much of a drug is going to be absorbed. Principles of chemistry are also applied while studying pharmacokinetics, because the interactions between drugs and body molecules represent a series of chemical reactions. Understanding the chemical encounters. between drugs and biological environments, such as the bloodstream and the oily surfaces of cells, is necessary to predict how much of a drug will be metabolized by the body. Pharmacodynamics refers to the effects of drugs in the body and the mechanism of their action. As a drug travels through the bloodstream, it exhibits a unique affinity for a drug receptor site, meaning how strongly it binds to the site. Drugs and receptor sites create a lock and key system that affect how drugs work and the presence of a drug in the bloodstream after it is administered. This concept is broadly termed as drug bioavailability. The bioavailability of drugs is an important feature that chemists and pharmaceutical scientists keep in mind when designing and packaging medicines. However, no matter how effectively a drug works in a laboratory simulation, the performance in the human body will not always produce the same results, and individualized responses to drugs have to be considered. Although many responses to medications may be anticipated, a person's unique genetic makeup may significantly impact their response to a drug. Pharmacokinetics is defined as the study of how people's genes affect their response to medicines. Figure 1.1 Pharmacodynamics, drug and receptor binding. 1.3% Absorption. Absorption. The first stage of pharmacokinetics is known as absorption. Absorption occurs after drugs enter the body and travel from the site of administration into the body's circulation. Medications can enter the body through various routes. Common routes to administer medications include the following examples: oral, enteral, rectal, intranasal, inhalation, intramuscular, subcutaneous, transdermal, intravenous. First pass effect. When a medication is administered orally or enterally, absorption may be significantly hindered in the gastrointestinal tract. For example, when medications made of protein are introduced into the GI tract, they can be quickly deactivated by enzymes as they pass through the stomach and duodenum. If some of the drug is absorbed from the intestine into the bloodstream, part of the absorbed portion may be broken down by liver enzymes, whereas the remaining part escapes into the general circulation. The portion of the drug that enters the general circulation will either become protein-bound or remain free to circulate and create an action at a receptor site. This entire process that results in reduced concentration of active drug available in an individual's circulation is known as the first pass effect. Due to the first pass effect, prescribing providers and nurses administering medications must understand that several doses of an oral medication may be needed before enough free drug stays active in the circulation to exert the desired effect. These metabolic effects are further described in the metabolism section later in this chapter. Alternate routes. A workaround to the first pass effect is to administer medication using alternate routes to the GI tract. Examples of alternative routes that avoid the first pass effect include transdermal, nasal, inhalation, injection, or intravenous administration of medication. Alternative routes of medication administration bypass the first pass effect by entering the bloodstream directly or via absorption through the skin or lungs. For example, pain relievers may be administered directly into the bloodstream, so they are quickly available for distribution to tissues within the body. Alternative routes of medication have other potential considerations. For example, injections are often painful and cause a break in the skin, an important barrier to infection. They can also be costly and difficult to administer daily, may cause localized side effects, or contribute to unpredictable fluctuations in medication blood levels. Transdermal application of medication is an alternate route that has the primary benefit of slow, steady drug delivery directly to the bloodstream, without passing through the liver first. See Figure 1.2 for an image of a client self-administering a transdermal patch. Drugs delivered transdermally enter the blood via a meshwork of small arteries, veins, and capillaries in the skin. This makes the transdermal route of drug delivery particularly useful when a medication must be administered over a longer period of time to control symptoms. For example, transdermal application of fentanyl, a pain medication, can provide effective pain management over several hours. A scopolamine patch can control motion sickness over the duration of a cruise ship vacation, and a nitroglycerin patch is used to prevent chronic chest pain. Despite their advantages, transdermal patches have a significant drawback in that only very small drug molecules can enter the body through the skin, making this application route inappropriate for some types of medications. Figure 1.2 applying transdermal patch. Inhaling drugs through the nose or mouth is another alternative route for rapid medication delivery that bypasses the liver. See Figure 1.3 for an image of a client self-administering an inhaler. Metered dose inhalers have been a mainstay of asthma therapy for several years, and nasal steroid medications are often prescribed for allergy and sinus problems. Figure 1.3 adult using inhaler. Researchers are currently exploring alternative methods of drug delivery, such as the use of inhaled insulin powders. Afrezza is an example of an inhaled insulin approved by the Food and Drug Administration to assist with blood sugar control. This technology stems from novel uses of chemistry and engineering to manufacture insulin particles of just the right size for absorption. If too large, the insulin particles could lodge in the lungs. If too small, the particles will be exhaled. Lifespan considerations. Neonate and pediatric. Gastric absorption in neonates and pediatric clients varies from adults. In infants, the acid-producing cells of the stomach are immature until around the age of 1 to 2 years. Additionally, gastric emptying may be decreased because of slowed or irregular peristalsis. The liver of infants and children is not fully mature, resulting in a decrease in first-pass elimination and subsequently higher drug levels in the bloodstream. Older adult. As a natural result of aging, older adults will experience decreased blood flow to tissues within the GI tract. In addition, there may be changes in the gastric pH that may alter the absorption of certain medications. Older adult clients may also experience variations in available plasma proteins, which can impact drug levels of medications that are highly protein-bound. Consideration must also be given to the use of subcutaneous and intramuscular injections in older clients experiencing decreased cardiac output, because decreased drug absorption of medications can occur when peripheral circulation is decreased. Additionally, As adults age, they often have less subcutaneous fat, resulting in decreased absorption of medication from transdermal patches that require adequate subcutaneous fat stores for 5 proper absorption. The box below summarizes route considerations that a nurse should consider when administering medication. Route considerations: oral or enteral ingestion. Oral route is a convenient route for administration of solid and liquid formulations. Additional variables that may influence the rate and extent of absorption include enteric coating or extended release formulations, acidity of gastric contents, gastric emptying rate, dietary contents, and presence of other drugs. First pass effect: blood containing the absorbed drug passes through the liver, which can deactivate a substantial amount of the drug and decrease its bioavailability. Parenteral injection. Subcutaneous and intramuscular administration. Injections can be difficult for clients to self-administer at home or to administer on a daily basis. They can be costly and painful. Injections also cause a break in skin that is an important barrier to infection, can cause fluctuation in drug levels, and can cause localized side effects to skin, such as bruising, redness, bleeding, and swelling. Intravenous. IV drugs are fully available to tissues after administration into the bloodstream, offering complete bioavailability and an immediate effect. However, this route requires intravenous access that can be painful to the client and also increases risk for infection. Medications must be administered in sterile fashion, and if 2 products are administered simultaneously, their compatibility must be verified. There is also an increased risk of toxicity to the kidneys or liver. Pulmonary inhalation. Inhalation allows for rapid absorption of drugs in gaseous, vaporized, or aerosol form through the lung tissue. Absorption of particulates, aerosols, depends on particle droplet size, which influences depth of entry through the pulmonary tree to reach the alveoli. The ability of the client to create successful inhalation, especially in the presence of bronchospasm, may also influence depth of entry in the pulmonary tree. Topical and transdermal application. Topical creams, lotions, and ointments are generally used for local effect. Transdermal patch formulations are used for systemic effect. Absorption through the buccal or sublingual membranes may be rapid and is used for systemic effect. Absorption through skin is generally slower, but produces a steady, long-term effect that avoids the first pass effect. However, absorption of medication is affected by blood's flow to the skin. For this reason, heat and cold applications should not be used over transdermal medications. 1.4% distribution. Distribution. The second stage of pharmacokinetics is the process known as distribution. Distribution is the process by which a drug is dispersed throughout the body's blood and tissues. After a drug enters into systemic circulation by absorption or direct administration, it will pass from vascular spaces to tissues where a drug receptor interaction will occur, creating the effect of the drug. Drugs are designed to primarily cause one effect, meaning they bind more strongly to one specific receptor site and predictably cause or block an action. However, side effects and adverse effects can occur when the drug binds to other sites in addition to the target tissue, causing an unintended action. These side effects can range from tolerable to unacceptable, and can result in the discontinuation of the medication. For example, a person might take the pain reliever ibuprofen to treat a sore leg muscle, and the pain may be subsequently relieved, but there may also be stomach irritation as a side effect. The distribution of a drug throughout the body is dependent on many body-related factors such as blood flow, tissue differences, plasma protein binding, the blood-brain barrier, and the placental barrier. Blood flow. The circulatory system transports medications throughout the body in the bloodstream. Many factors can affect the blood flow and delivery of medication, such as decreased blood flow, blocked vessels, constricted vessels, or weakened pumping by the heart muscle. As an example, when administering an antibiotic to a client with diabetes who has an infected toe, it may be difficult for the antibiotic to move through the blood vessels all the way to the area of the toe that is infected because of blocked vessels in the legs and feet due to atherosclerosis. Tissue differences. Distribution occurs most rapidly into tissues with a greater number of blood vessels that allow high blood flow. Distribution occurs least rapidly in tissues with fewer numbers of blood vessels, resulting in low blood flow. However, lipophilic drugs disproportionately distribute into adipose tissue in obese subjects. The permeability of capillaries is tissue dependent. Capillaries of the liver and kidney are porous, allowing for greater permeability. Distribution rates are relatively slower or non-existent into the central nervous system because of the tight junction between capillary endothelial cells and the blood-brain barrier. Protein binding. After a drug enters the bloodstream, a portion of it exists as free drug, dissolved in plasma water, but a portion of it becomes bound to proteins. This is important because only free and unbound drugs will pass from the bloodstream to tissues where drug receptor interactions will occur, thus producing the first effects of a medication. The other portion of the drug that becomes protein-bound is inactive while it is bound. For many drugs, these bound forms can account for 95 to 98% of the total. Protein binding can also act as a reservoir as the drug is released slowly, causing a prolonged action. When considering drug distribution, it is important to consider both the amount of free drug that is readily available to tissues as well as the protein binding that causes the drug to be released over time. Albumin is one of the most important proteins in the blood. Albumin levels can be decreased by several factors, such as malnutrition and liver disease. Therefore, clients with low albumin levels may experience differences in the desired actions of administered medication because of the consequence effect on protein binding and distribution. Competition for plasma binding can also impact the effects of drugs. For example, aspirin and warfarin are anticoagulants that compete for the same plasma protein binding site. Administering both drugs at the same time will increase the amount of unbound drug, thereby increasing their effects and increasing the client's risk for bleeding. Figure 1.4 Protein binding like available seats on a bus. As an analogy of how protein binding affects the distribution of medications, consider passengers at a bus stop going to their destination. See Figure 1.4 for an image of a bus related to this analogy. Many passengers want to take a ride on the bus. Everyone is eager to get to their destination and tries to find a seat. Some passengers are stronger than others and take all the seats first. When there aren't enough seats on the bus, some passengers are left at the bus stop and become free to move around or walk to their destination. In a similar way, free drug molecules that are not protein-bound circulate freely in the bloodstream. The free passengers in this analogy may go directly to their destination, or they may stop at other locations along the route. In a similar manner, free drug molecules produce the first intended or unintended effects in the body when they attach to receptors. Furthermore, similar to the passengers who had seats on the bus, and then later got off at their destination, the medication molecules attached to proteins are eventually released and attached to the receptor sites. Blood-brain barrier. Medications destined for the central nervous system face an even larger hurdle than protein binding. They must also pass through a nearly impenetrable barricade called the blood-brain barrier. This blockade is built from a tightly woven mesh of capillaries that protect the brain from potentially dangerous substances, such as poisons or viruses. Only certain medications made of lipids or those with a carrier can get through the blood-brain barrier. Scientists have devised ways for medications to penetrate the blood-brain barrier. For example, the brand-named medication Sinemet is a combination of two drugs, carbidopa and levodopa. Carbidopa is designed to carry the levodopa medication across the blood-brain barrier, where it enters the brain and is converted into dopamine to exert its effect on symptoms related to Parkinson's disease. Some medications inadvertently bypass the blood-brain barrier and impact an individual's central nervous system function as a side effect. For example, diphenhydramine is an antihistamine used to decrease allergy symptoms. However, it can also cross the blood-brain barrier, depress the central nervous system, and cause the side effect of drowsiness. In the case of a person who has difficulty falling asleep, this drowsy side effect may be useful, but for a person trying to carry out daily activities, drowsiness can be problematic. Placental barrier. The placenta links mother and fetus, and the blood-placental barrier regulates transfer of molecules between maternal and fetal circulation to protect the fetus. Drug transporters are involved in transport of drugs through the placenta, affecting potential drug distribution to the fetus. The placenta is known to be permeable to some medications, and furthermore, some drugs can cause significant harm to the fetus. However, many medications have not been specifically studied in pregnant clients, and their effects on the fetus are unknown. For this reason, it is always important to consider the potential effects of medication on the fetus if it is administered to a client who is pregnant or who may become pregnant. Nurses play a critical role in notifying the healthcare provider regarding potential safety concerns. If medication can be distributed to the fetus, nurses must always check a recent, evidence-based drug reference before administering medications to a client who is pregnant or may become pregnant. This imperative is implied in the remaining chapters. Lifespan considerations, neonate and pediatric. Fat content in infants and children is decreased because of greater total body water. Additionally, protein binding capacity is decreased, and the developing blood-brain barrier allows more drugs to enter the central nervous system. Older adult. At the same body mass index, older adults, on average, tend to have more body fat than younger adults. This increased body fat can result in a longer duration of action for many medications that accumulate in fatty tissues. Serum albumin also decreases, resulting in more active free drugs circulating within the body. For these reasons related to distribution, many older adult clients require lower dosages of medication. 1.5% metabolism. After a drug has been absorbed and distributed throughout the body, it is broken down by a process known as metabolism so that it can be excreted from the body. Drugs undergo chemical alteration by various body systems to create compounds that are more easily excreted. As previously discussed in this chapter, medications that are swallowed or otherwise administered into the gastrointestinal tract are inactivated by the intestines and liver, known as the first-pass effect. Additionally, everything that enters the bloodstream, whether swallowed, injected, inhaled, absorbed through the skin, or produced by the body itself, is metabolized by the liver. See Figure 1.5 for an image of the liver. These chemical alterations are known as biotransformations. The biotransformations that take place in the liver are performed by liver enzymes. Figure 1.5 Liver. Biotransformations occur by mechanisms categorized as either phase 1, phase 2, and in some instances, phase 3-2. Phase 1. Biotransformations alter the chemical structure of the drug. Many of the products of enzymatic breakdown, called metabolites, are less chemically active than the original molecule. For this reason, the liver is referred to as a detoxifying organ. An example of a phase 1 biotransformation is when diazepam, a medication prescribed for anxiety, is transformed into desmethyldiazepam and then to oxazepam. Both these metabolites produce similar physiological and psychological effects of diazepam. In some instances, phase 1 biotransformations change an inactive drug into an active form called a prodrug. Prodrugs improve a medication's effectiveness. They may also be designed to avoid certain side effects or toxicities. For example, sulfasalazine is a medication prescribed for rheumatoid arthritis. It is prodrug that is not active in its ingested form, but becomes active after phase 1 modification. Phase 2 biotransformations involve reactions that couple the drug molecule with another molecule in a process called conjugation. Conjugation typically renders the compound pharmacologically inert and water-soluble so it can be easily excreted. These processes can occur in the liver, kidney, lungs, intestines, and other organ systems. An example of phase 2 metabolism is when oxazepam, the active metabolite of diazepam, is conjugated with a molecule called glucuronide, so that it becomes physiologically inactive and is excreted without further chemical modification. Following phase 2 metabolism, phase 3 biotransformations may also occur, where the conjugates and metabolites are excreted from cells. Factors affecting metabolism. Critical factors in drug metabolism are the type and concentration of liver. 5. This work is a derivative of stat pearls by Sousa, Hussein, and Prius, and is licensed under CC by 4. Enzymes. The most important enzymes for medical purposes are monoamine oxidase and cytochrome P450. These two enzymes are responsible for 6 metabolizing dozens of chemicals. Drug metabolism can be influenced by a number of factors. One major disruptor of drug metabolism is depot binding. Depot binding is the coupling of drug molecules with inactive sites in the body, resulting in the drug not being accessible for metabolism. This action can also affect the duration of action of other medications susceptible to depot binding. For example, tetrahydrocannabinol, the main psychoactive component of marijuana, is highly lipid soluble, and depot binds in the adipose tissue of users. This interaction drastically slows the metabolism of the drug, so metabolites of THC can be detected in urine weeks after the last use. Another factor in drug metabolism is enzyme induction. Enzymes are induced by repeated use of the same drug. The body becomes accustomed to the constant presence of the drug and compensates by increasing the production of the enzyme necessary for the drug's metabolism. This contributes to a condition referred to as tolerance and causes clients to require ever-increasing doses of certain drugs to produce the same effect. For example, clients who take opioid analgesics over a long period of time will notice that their medication becomes less effective over time. In contrast, some drugs have an inhibitory effect on enzymes, making the client more sensitive to other medications metabolized through the action of those enzymes. For example, monoamine oxidase inhibitors are prescribed as antidepressants because they block monoamine oxidase, the enzyme that breaks down serotonin and dopamine, thus increasing the concentration of these chemicals in the central nervous system. However, this can cause problems when clients taking an MAOI also take other medications that increase the levels of these chemicals, such as dextromethorphan found 9% in cough syrup. Additionally, drugs that share metabolic pathways can compete for the same binding sites on enzymes, thus decreasing the efficiency of their metabolism. For example, alcohol and some sedatives are metabolized by the cytochrome P450 enzyme, and only a limited number of these enzymes exist to break these drugs down. Therefore, if a client takes a sedative after drinking alcohol, the sedative is not well metabolized because most of cytochrome P450 enzymes are filled by alcohol molecules. This results in reduced excretion and high levels of both drugs in the body with enhanced effects. For this reason, the co-administration of alcohol and sedatives can be deadly. Clinical significance. When administering medication, nurses must know how and when the medication is metabolized and eliminated from the body. Most of the time, the rate of elimination of a drug depends on the concentration of the drug in the bloodstream. However, the elimination of some drugs occurs at a constant rate that is independent of plasma concentrations. For example, the ethanol contained in alcoholic beverages is eliminated at a constant rate of about 15% ml/hour, regardless of the concentration in the bloodstream. Half-life. Half-life refers to the rate at which 50% of a drug is eliminated from the body. Half-life can vary significantly between drugs. Some drugs have a short half-life of only a few hours and must be given multiple times a day, whereas other drugs have half-lives exceeding 12 hours and can be given as a single dose 11 every 24 hours. See Figure 1.6 for an illustration of half-life affecting the blood concentration of medication over time. Figure 1.6. Half-life affecting blood concentration of medication over time. Half-life affects the duration of the therapeutic effect of a medication. Many factors can influence half-life. For example, liver disease can prolong half-life if it is no longer effectively metabolizing the medication. Information about half-life of a specific medication can be found in evidence-based medication references. For example, in the clinical pharmacology section of the Daily Med reference for furosemide, the half-life is approximately 2 hours. Depending on whether a drug is metabolized and eliminated by the kidneys or liver, impairment in either of these systems can significantly alter medication dosing, frequency of doses, anticipated therapeutic effect, and even whether a particular medication can be used at all. Nurses must work with other members of the healthcare team to prevent drug interactions that could significantly affect a client's health and well-being. Nurses must be alert for signs of a toxic buildup of metabolites or active drugs, particularly if the client has liver or kidney disease, so that they can alert the healthcare provider. In other cases, drugs such as warfarin and certain antibiotics are dosed and monitored by pharmacists, who monitor serum levels of the drugs, as well as kidney function. Lifespan considerations: neonate and pediatric. The developing liver in infants and young children produces decreased levels of enzymes. This may result in a decreased ability of the young child or neonate to metabolize medications. In contrast, older children may experience increased metabolism and require higher doses of medications once the hepatic enzymes are fully produced. Older adult. Metabolism by the liver may significantly decline in the older adult. As a result, dosages should be adjusted according to the client's liver function and their anticipated metabolic rate. First-pass metabolism also decreases with aging, so older adults may have higher free circulating drug concentrations and thus be at higher risk for side effects and toxicities. 12. Fernandez E., Perez R., Hernandez A., Tejada P., Arteta M., and Ramos J.T. Factors and mechanisms for pharmacokinetic differences between pediatric population and adults. Pharmaceutics 3, 53 to 72. 10.3390 Pharmaceutics. 13. Fernandez E., Perez R. 10.3390 Pharmaceutics. Metabolism can be influenced by many factors within the body. If a client has liver damage, they may not be able to break down medications as efficiently. Dosages are calculated according to the liver's ability to metabolize and the kidney's ability to excrete. When caring for a client with cirrhosis, how can this condition impact the dosages prescribed? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Did you know? Did you know that, in some people, a single glass of grapefruit juice can alter levels of drugs used to treat allergies, heart diseases, and infections? 15 years ago, pharmacologists discovered this grapefruit juice effect by luck, after giving volunteers grapefruit juice to mask the taste of a medicine. Nearly a decade later, researchers figured out that grapefruit juice affects the metabolizing rates of some medicines by lowering levels of a drug metabolizing enzyme called CYP3A4 in the intestines. Paul B. Watkins of the University of North Carolina at Chapel Hill discovered that other juices like Seville orange juice, but not regular orange juice, have the same effect on the liver's ability to metabolize using enzymes. Each of 10 people who volunteered for Watkins' juice medicine study took a standard dose of felidopine, a drug used to treat high blood pressure, diluted in grapefruit juice, sour, orange juice, or plain orange juice. The researchers measured blood levels of felidopine at various times afterward. The team observed that both grapefruit juice and sour orange juice increased blood levels of felidopine, as if the people had received a higher dose. Regular orange juice had no effect. Watkins and his co-workers have found that a chemical common to grapefruit and sour oranges, dihydroxybergamotin, is likely the molecular culprit. Thus, when taking medications that use the CYP3A4 enzyme to metabolize, clients are advised to avoid grapefruit juice and sour orange juice. Grapefruit by Explorer Bob is licensed under CC 0. 1.6 Excretion. Excretion is the final stage of a medication interaction within the body. The body has absorbed, distributed, and metabolized the medication molecules. Now, what does it do with the leftovers? Remaining parent drugs and metabolites in the bloodstream are often filtered by the kidney, where a portion undergoes reabsorption back into the bloodstream, and the remainder is excreted in the urine. The liver also excretes byproducts and waste into the bile. Another potential route of excretion is the lungs. For example, drugs like alcohol and the anesthetic gases are often eliminated by the lungs. Routes of excretion. Kidney. The most common route of excretion is through the kidneys. As the kidneys filter blood, the majority of drug byproducts and waste are excreted in the urine. The rate of excretion can be estimated by taking into consideration several client factors, including age, weight, biological sex, and kidney function. There are known sex differences in the three main renal functions of glomerular filtration: tubular secretion and tubular reabsorption. Renal clearance is generally higher in men than in women. Kidney function is measured by lab values such as serum creatinine, glomerular filtration rate, and creatinine clearance. If a client's kidney function is decreased, then their ability to excrete medication is affected, and drug dosages must be altered for safe administration. Renal disorders, such as chronic kidney disease, can reduce kidney function and hinder drug excretion. As kidney function decreases with age, drug excretion becomes less efficient, and dosing adjustments may be needed. Other medical conditions that impact blood flow to the kidneys can also affect drug elimination. For example, heart failure can affect systemic blood flow to the kidney, resulting in decreased filtration and elimination of drugs. Liver. As the liver filters blood, some drugs and their metabolites are actively transported by hepatocytes to bile. Bile moves through the bile ducts to the gallbladder and then on to the small intestine. During this process, some drugs may be partially absorbed by the intestine back into the bloodstream. Other drugs are biotransformed by intestinal bacteria and reabsorbed. Unabsorbed drugs and byproducts, metabolites, are excreted in the feces. If a client has decreased liver function, their ability to excrete medication is affected, and drug dosages must be adjusted. Lab studies used to evaluate liver function are called liver function tests and include measurement of alanine transaminase and aspartate aminotransferase enzymes that the body releases in response to damage to or disease of the liver. Conditions that cause decreased blood flow to the liver can also affect the metabolism and excretion of drugs. For example, conditions such as shock, hypovolemia, or hypotension cause decreased liver perfusion and may require adjustment of dosages of medication. Other routes to consider: sweat, tears, reproductive fluids, and breast milk can also contain drugs and byproducts, metabolites of drugs. This can pose a toxic threat, such as the exposure of an infant to breast milk containing drugs or byproducts of drugs ingested by the mother. Therefore, nurses must refer to a drug reference and contact a healthcare provider with any concerns before administering medications to a mother who is breastfeeding. Lifespan considerations: neonate and pediatrics. Neonates and children have immature kidneys with decreased glomerular filtration, resorption, and tubular secretion. As a result, they do not excrete medications as efficiently from the body. dosing for most medications used to treat infants and pediatric clients is commonly based on weight in kilograms, and a smaller dose is usually prescribed. In addition, pediatric clients may have higher levels of free circulating medication than anticipated, and may become toxic quickly. Therefore, it is vital for nurses to diligently recheck dosages before administering medications and closely monitor infants and children for early identification of adverse effects and drug-for toxicity. Older adult, kidney and liver function often decrease with age, which can lead to decreased metabolism and excretion of medications. Subsequently, medication may have a prolonged half-life with a greater potential for toxicity due to elevated circulating drug levels. Some medications may be avoided or smaller doses recommended for older clients due to these factors, which is commonly referred to as start low and go slow, putting it all together. Safely administering medications to clients is a significant concern and requires team effort by pharmacists, prescribing healthcare providers, and nurses. In addition to the factors described in this chapter, there are many other considerations for safe medication administration that are further explained in the legal, ethical chapter. Critical Thinking Activity 1.6. When providing care for a client who has chronic kidney disease, how does this condition impact medication excretion? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Interactive activity. An interactive HSP element has been excluded from this version of the text. You can view it online here. Pharmacokinetics quiz by E. Kreisman for OpenRN is licensed under CC by 4. 1.7 Pharmacodynamics. Pharmacodynamics. So far in this chapter, we have learned the importance of pharmacokinetics in how the body absorbs, distributes, metabolizes, and excretes a medication. Now let's consider how drugs act on target sites of action in the body, referred to as pharmacodynamics. Mechanism of action is a medical term that describes how a medication works in the body. For example, did you know that an osmotic laxative like magnesium citrate attracts and binds with water? The mechanism of action for this medication is it pulls water into the bowel, which softens stool and increases the likelihood of a bowel movement. A drug's mechanism of action may refer to how it affects a specific receptor. Many drugs bind to specific receptors on the surface of cells to cause an action. For example, morphine binds to a specific receptor that inhibits transmission of nerve impulses along the pain pathway and decreases a client's feelings of pain. Other medications inhibit specific enzymes for a desired effect. For example, earlier in this chapter, we discussed how monoamine oxidase inhibitors are prescribed as antidepressants because they block monoamine oxidase, the enzyme that breaks down serotonin and dopamine. This blockage increases the concentration of serotonin and dopamine in the central nervous system and increases a client's feelings of pleasure. Agonist and antagonist actions. Drugs have agonistic or antagonistic effects on receptor sites. An agonist binds tightly to a receptor to produce a desired effect. An antagonist competes with other molecules and blocks a specific action or response at a one receptor site. See Figure 1.7 for an illustration of how a beta blocker, an antagonist cardiac medication, blocks specific action on the beta receptors of a cardiac cell. Figure 1.7 Antagonist action of beta blockers on beta receptors of a cardiac cell. Agonistic and antagonistic effects on receptors for common classes of medications are further discussed in the autonomic nervous system chapter. Critical thinking activity 1.7. Atenolol is an antagonist medication. Does the nurse anticipate this will cause a specific action or block a specific action at a receptor site? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. 1.8 Types of medications. There are a variety of drugs and substances that clients may utilize for symptom management or to enhance their wellness. Nurses document clients' use of prescription medications, over-the-counter medications, herbal substances, and other supplements in the medical record. Some substances have a long half-life and have the potential to interact with new medications, so accuracy is vital. Ensuring an accurate medical record and knowledge of the different types of substances a client is taking is important for an effective nursing plan of care. Prescription medications. Drugs are prescribed by a licensed prescriber for a specific person's use and regulated through the United States Food and Drug Administration. More information about FDA approval of medications is described in the legal ethical chapter. Prescription medications include brand name medications and generic medications. Common prefixes, suffixes, and roots for classes of medication. Table 1.8 provides prefixes, suffixes, and roots associated with common prescription medications. As a nurse, familiarizing yourself with the content in the table can help you to quickly organize medications based on their name and recall their mechanism of action and identify potential interactions or side effects. This knowledge can improve your ability to safely administer medications and provide health teaching. Ultimately, this knowledge can lead to improved client outcomes, increased satisfaction, and a reduced risk of adverse events and medication errors. Table 1.8 Common classes of medications, examples, suffixes, and roots. Generic medications. Generic medications can be safe and effective alternatives to their brand name counterparts at a significantly reduced cost. By law, generic medications must have the same chemically active ingredient in the same dose as the brand name. However, the excipients or the flavoring can be different. Some clients do not tolerate these differences in excipients very well. When prescribing a medication, the provider must indicate that a generic substitution is acceptable. Nurses are often pivotal in completing insurance paperwork on the client's behalf if the brand name medication is more effective or better tolerated by that particular client. When studying medications in nursing school and preparing for the NCLEX, it is important to know medications by their generic name, because the NCLEX does not include brand names in their questions. Over-the-counter medications. Over-the-counter medications do not require a prescription. They can be bought at a store and may be used by multiple individuals. OTC medications are also regulated through the FDA. Some prescription medications are available for purchase as OTC in smaller doses. For example, diphenhydramine is commonly prescribed as 50 milligrams every 6 hours, and the prescription strength is 50 milligrams. However, it can also be purchased OTC in 25 milligrams doses. Herbals and supplements. Herbs and supplements may include a wide variety of substances, including vitamins, minerals, enzymes, and botanicals. Supplements such as protein powders are marketed to build muscle mass and can contain a variety of substances that may not be appropriate for all individuals. Herbals and supplements are often considered complementary and alternative medications. Complementary and alternative medications are types of therapies that are commonly used in conjunction with or as an alternate to traditional medical therapies. These herbal and supplement substances are not regulated by the FDA, and most have not undergone rigorous scientific testing for safety for the public. While clients may be tempted to try these herbals and supplements, there is no guarantee that they contain the ingredients listed on the label. It is also important to remember that there is a potential for adverse effects or even overdose if the herbal or supplement contains some of the same drug that was also prescribed to a client. By understanding the use of CAM therapies, nurses can help their clients make informed decisions and take a holistic approach to their care. Additionally, being knowledgeable about CAM therapies can help nurses to better educate their clients on the potential benefits and risks associated with these therapies, which can help improve client outcomes and satisfaction. Read additional information on complementary and alternative medicine at the National Center for Complementary and Integrative Health database. 1.9% efficacy, dose response, onset, peak, and duration. Dosing considerations play an important role in understanding the effect that a medication may have on a client. During administration, the nurse must pay close attention to the desired effect and therapeutic response, as well as the safe dose range for any medication. The nurse should have an understanding of medication efficacy in order to ensure its appropriateness. If a nurse is provided a variety of medication choices according to a provider's written protocol, the nurse should select the option with the anticipated desired therapeutic response. Additionally, the nurse must be aware of the overall dose response based on the dosage selected. Dose response is the dose of medication required to achieve the desired response to the medication. As the dose increases, the response of the drug may increase, as well as the potential for toxicity. This response helps determine the therapeutic index of a drug, or the effective dose range. The measured response and dose are often graphed perpendicular to each other, with the slope of the graph's curve representing therapeutic index. It is important to note that some medications have a very small therapeutic window, and even small increases in dosages can result in toxic effects. See Figure 1.8 for an illustration of a dose-response graph. Figure 1.8 Dose-response graph. Onset, peak, and duration. 3 additional principles related to the effect a medication has on a client are onset, peak, and duration. Onset of medication refers to when the medication first begins to take effect. Time of onset is affected by the route of administration. For example, a diuretic given intravenously will begin to take effect much faster than a diuretic administered orally because the intravenous route delivers the drug directly to the systemic circulation and avoids the first-pass effect. Peak refers to the maximum concentration of medication in the body, and the client shows evidence of greatest therapeutic effect. For example, a client taking ibuprofen can anticipate maximum pain relief in 1 to 2 hours when the medication reaches peak serum levels. Duration refers to the length of time the medication produces its desired therapeutic effect. For example, the duration of oral acetaminophen is 4 to 6 hours, at which time the client will likely require an additional dose for pain. Duration, dosing, and steady state. Now let's consider the implication of duration and dosing. Remember, the duration of medication is correlated with the elimination. Half-life is the amount of time that it takes for half of the drug to be eliminated from the body. If a medication has a short half-life, the therapeutic effect is shorter. These medications may require repeated dosing throughout the day in order to achieve steady blood levels of active free drug and a sustained therapeutic effect. Other medications have a longer half-life and may only be administered once or twice per day. For example, oxycodone immediate release is prescribed every 4 to 6 hours for the therapeutic effect of immediate relief of severe pain, whereas oxycodone ER is prescribed every 12 hours for the therapeutic effect of sustained relief of severe pain. Steady state refers to the point at which the amount of drug entering the body is equal to the amount of drug being eliminated, resulting in a stable 2-drug concentration. When steady state is achieved, there is a state of equilibrium in the body, and the concentration of the drug remains constant, resulting in optimal therapeutic effect. Clinical example. Consider this client care example and apply the principles of onset, peak, and duration. A 67-year-old female postoperative client rings the call light to request medication for pain related to the hip replacement procedure she had earlier that day. She notes her pain is excruciating, a definite 9 out of 10. Her brow is furrowed, and she is grimacing in obvious discomfort. As the nurse providing care for the client, you examine her postoperative medication orders and consider the pain medication options available to you. In reviewing the various options, it is important to consider how quickly a medication will work, when the medication will reach maximum effectiveness, and how long the pain relief will last. Understanding these principles is important in effectively relieving the client's pain and constructing an overall plan of care. Critical thinking activity 1.9. 1. At 0500, your client who had a total knee replacement yesterday rates his pain while walking as 7 out of 10. Physical therapy is scheduled at 0900. The client has acetaminophen 625 milligrams ordered every 4 hours as needed for discomfort. What should you consider in relation to the administration and timing of the client's pain medication? 2. Your client is prescribed NPH insulin to be given at breakfast and supper. As a student nurse, you know that insulin is used to decrease blood sugar levels in clients with diabetes mellitus. During report, you hear that the client has been ill with GI upset during the night, and the nursing assistant just informed you he refused his breakfast tray. While reviewing this medication order, you consider the purpose of the medication and information related to the medication's onset, peak, and duration. When reviewing the drug reference, you find the NPH insulin has an onset of about 1 to 3 hours after medication administration. What should you consider in relation to the administration and timing of the client's insulin? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. 1.10 Therapeutic Levels. Now that the concepts of dose response, onset, peak, and duration have been discussed, it is important to understand the therapeutic window and therapeutic index. Therapeutic window. For every drug, there exists a dose that is minimally effective and another dose that is toxic. Between these doses is the therapeutic window, where the safest and most effective treatment will occur. For example, see Figure 1.9 for an illustration of the therapeutic window for warfarin. a medication used to prevent blood clotting. Too much warfarin administered causes bleeding, and vitamin K is required as an antidote. Conversely, not enough warfarin administered for a client's condition can cause clotting. Think of the therapeutic window as the perfect dose, where clotting is prevented, and yet bleeding does not occur. Figure 1.9 Therapeutic Window. The effect of warfarin is monitored using a blood test called International Normalized Ration. For clients receiving warfarin, nurses vigilantly monitor their INR levels to ensure the dosage appropriately reaches their therapeutic window and does not place them at risk for bleeding or clotting. Peak and trough levels. Now let's apply the idea of therapeutic window to the administration of medications requiring the monitoring of peak and trough levels, which is commonly required in the administration of specific IV antibiotics. The dosage of these medications is titrated, meaning adjusted for safety, to achieve a desired therapeutic effect for the client. Titration is accomplished by closely monitoring the peak and trough levels of the medication. A drug is said to be within the therapeutic window when the serum blood levels of an active drug remain consistently above the level of effective concentration and consistently below the toxic level. A peak drug level is drawn after the medication is administered and is known to be at the highest level in the bloodstream. A trough level is drawn when the drug is at its lowest in the bloodstream, right before the next scheduled dose is given. Medications have a predicted reference range of normal values for peak and trough levels. These numbers assist the pharmacist and provider in gauging how the body is metabolizing, protein binding, and excreting the drug and are used to adjust the prescribed dose to keep the medication within the therapeutic window. When administering IV medications that require peak or trough levels, it is vital for the nurse to plan the administration of the medication according to the timing of these blood tube draws. Therapeutic Index. The therapeutic index is a quantitative measurement of the relative safety of a drug. It is a comparison of the amount of drug that produces a therapeutic effect versus the amount of drug that produces a toxic effect. A large therapeutic index number means there is a wide therapeutic window between the effective concentration and the toxic concentration of a medication, so the drug is relatively safe. A small therapeutic index number means there is a narrow therapeutic window between the effective concentration and the toxic concentration. A drug with a narrow therapeutic range often has the dosage titrated according to measurements of the actual blood levels achieved in the person taking it. For example, phenytoin has a narrow therapeutic index between the effective and toxic concentrations. Clients who start taking phenytoin to control seizures have frequent peak and trough drug levels to ensure they achieve steady state, with a therapeutic dose to prevent seizures without reaching toxic levels. Critical thinking activity 1.10. Mr. Parker has been receiving gentamicin 80 mg IV 3 times daily to treat his infective endocarditis. He has his gentamicin level checked 1 hour after the end of his previous gentamicin infusion was completed. The result is 30 mcg/ml. Access the information below to determine the nurse's course of action. View information on therapeutic drug levels. After accessing the information, be sure to select Click to Keep. Reading in order to view drugs that are commonly checked, their target levels, and what abnormal results mean. Based on the results in the above client scenario, what action will the nurse take based on the result of the gentamicin level of 30 mcg/ml? Note: Answers to the critical thinking activities can be found in the answer key section at the end of the book. 1.1. 1. Evaluating effects. Evaluating the effects. The nurse is responsible for assessing the client, monitoring lab values, and recognizing side effects and/or adverse effects of medications. Drug dosages should be verified to ensure all are within recommended safe ranges according to the client's current status, as well as for their potency. Potency refers to the amount of the drug required to produce the desired effect. A drug that is highly potent may require only a minimal dose to produce a desired therapeutic effect, whereas a drug that has low potency may need to be given at much higher concentrations to produce the same effect. Consider the example of opioid versus non-opioid medications for pain control. Opioid medications often have a much higher potency in smaller doses to produce pain relief. Therefore, the overall dose required to produce a therapeutic effect may be much less than that for other analgesics. The nurse preparing to administer medications must also be cognizant of drug selectivity and monitor for potential side effects and adverse effects. Selectivity refers to the separation between the desired and undesired effects of a drug. Drugs that are selective will search out target sites to create a specific drug action, whereas non-selective drugs may impact many other types of cells and tissues, thus increasing the risk for unintended side effects and/or adverse effects. For example, in Chapter 4, selective and non-selective beta blockers will be discussed. Selective beta-1 blockers search out specific receptors on the heart to create their effect, whereas non-selective beta blockers may affect receptors in the lungs in addition to those in the heart, causing potential respiratory side effects like a cough. A side effect occurs when the drug produces effects other than the intended effect. A side effect, although often unintended, is generally anticipated by the provider and is a known potential consequence of the medication therapy. Examples of common side effects are nausea, vomiting, diarrhea, and drowsiness. In some situations, however, side effects may have a beneficial impact. For example, a side effect of hydrocodone is drowsiness. A client who is having difficulty sleeping due to pain and takes hydrocodone at bedtime may find the drowsiness beneficial in helping them fall asleep. Conversely, unanticipated effects can occur from medications that are harmful to the client. These harmful occurrences are known as adverse effects. Adverse effects are relatively unpredictable, severe, and are reason to discontinue the medication. For example, an adverse effect of ciprofloxacin is tendon rupture. Adverse effects should be reported to the pharmacy and tracked as a client safety concern according to agency policy. 1.12 Learning activities. You have been introduced to many concepts related to pharmacokinetics and pharmacodynamics in this chapter. These basic concepts are important to understand as we examine various medication classes. Interactive activity. An interactive H5P element has been excluded from this version of the text. You can view it online here. Medication absorption quiz by E. Christman for OpenRN is licensed under CC by 4. Interactive activity. An interactive H5P element has been excluded from this version of the text. You can view it online here. Pharmacokinetics flashcards by E. Christman for OpenRN is licensed under CC by 4. Test your knowledge and application. Use the information in the text above, as well as the Daily Med resource, to read more about the medications included in the client scenarios. Additional pharmacokinetics information can be found under the clinical pharmacology section of each drug in Daily Med. 1. You are working in a nursing home caring for an 86-year-old stroke client who complains of left knee pain secondary to arthritis. The client has right-sided weakness and difficulty swallowing with no gag reflex. You review the client's medication administration record and note the provider has prescribed acetaminophen 325 mg, either per oral or per rectal route. Which route would you choose and why? 2. Mr. Johnson is a 92-year-old male admitted to the medical surgical unit for severe pneumonia, and the provider prescribed gentamicin antibiotic therapy. Upon review of the order, you notice the initial dose is ordered at less than the standard recommended dose. What is the rationale behind the decreased starting gentamicin dose for this client? 3. Sarah is a nurse working on the medical surgical floor. She is reviewing her client's chart and notes her client has a 0,600 vancomycin infusion. However, the trough level is not available. The nurse phones the lab, and they state they will not be available to draw the trough level for an hour. What actions should the nurse take? 4. Sam is a nurse working on the cardiology floor. He has an order to administer a dose of atenolol to a client at 0,800. What actions should the nurse take prior to administering the medication? What is the anticipated therapeutic effect of this medication? 5. Julia is a 56-year-old client admitted to the cardiology unit with new-onset atrial fibrillation. She has been prescribed amiodarone for her irregular heartbeat and is set to receive her first dose with her morning breakfast tray. When you arrive in the room, you notice that she has grapefruit juice on her breakfast meal tray. Is this a concern? Why? As the nurse, what is your next action? 6. A nurse is caring for a 55-year-old male who recently was admitted to the medical surgical unit for a total knee replacement. He is prescribed hydrocodone acetaminophen 325 milligrams every 6 hours for moderate pain. The client complains of pain in the knee, rating it at a 6. Review the clinical pharmacology section for this medication using the chart. When does the nurse anticipate the medication will peak in action? When does the nurse anticipate another dose will be needed due to the half-life of this drug? Note: answers to the light bulb moment can be found in the answer key section at the end of the book. Test your clinical judgment with this. NCLEX Next Generation Style Bowtie Question Pain Medication I Glossary Absorption, the first stage of pharmacokinetics where medications enter the body and travel from site of administration into the body's circulation. Adverse effect, an unintended and potentially dangerous pharmacological effect that occurs when a medication is administered correctly. Affinity, the strength of binding between drug and receptor. Agonist, a drug that binds to a receptor and produces an effect. Antagonist, a molecule that prevents the action of other molecules, often by competing for a cellular receptor. Opposite of agonist. Bioavailability, the presence of a drug in the bloodstream after it is administered. Blood-brain barrier, a nearly impenetrable barricade that is built from a tightly woven mesh of capillaries cemented together to protect the brain from potentially dangerous substances such as poisons or viruses. Distribution, the second stage of pharmacokinetics where medication is dispersed throughout the body via the bloodstream. Dose response, the dose of medication required to achieve the desired response to the medication. Duration, the length of time that a medication is producing its desired therapeutic effect. Efficacy, the maximum effect of which the drug is capable. Excretion, the final stage of pharmacokinetics where drug byproducts and metabolites are eliminated from the body. First pass effect, the inactivation of orally or enterally administered drugs in the liver and intestines. Mechanism of action, how a medication works at a cellular level within the body. Metabolism, the third stage of pharmacokinetics that involves the breakdown of a drug so that it can be excreted by the body. Onset, when a medication first begins to work and exerts a therapeutic effect. Peak, when the maximum concentration of a drug is in the bloodstream. Pharmacodynamics, the effects of drugs in the body and the mechanism of their action. Pharmacogenetics, the study of how a person's genetic makeup affects their response to medicines. Pharmacokinetics, the study of how the body absorbs, distributes, metabolizes, and eliminates drugs. Pharmacology, the science dealing with actions of drugs on the body. Pharmacy, the science of the preparation of drugs. Potency, the drug dose required to produce a specific intensity of effect. Selectivity, the separation between the desired and undesired effects of a drug. Side effect, effect of a drug, other than the desired effect, sometimes in an organ other than the target organ. Therapeutic index, a quantitative measurement of the relative safety of a drug that compares the amount of drug that produces a therapeutic effect versus the amount of drug that produces a toxic effect. Medication with a large therapeutic index is safer than a medication with a small therapeutic index. Therapeutic window, the dosing window in which the safest and most effective treatment will occur,